Dysmenorrhea refers to the painful uterine cramps that occur just before or during menstruation. It is the most frequent gynecologic cause for school or work absenteeism among females. The pain arises from involuntary uterine muscle contractions that temporarily restrict blood flow, activating nociceptors that transmit pain signals to the central nervous system. For example, a 16-year-old high school student may skip a morning class because the cramping is severe enough to interfere with concentration and mobility. Dysmenorrhea can be classified as primary without an underlying disease, or secondary caused by conditions such as endometriosis. The primary etiologic factor in dysmenorrhea is the surge of prostaglandins, particularly PGF2-alpha, produced by the endometrium during the luteal phase. These lipid mediators stimulate myometrial hypercontractility and vasoconstriction. Secondary causes include hormonal imbalances. For example, low progesterone structural lesions, such as endometriosis, adenomyosis, uterine fibroids, and lifestyle contributors such as chronic stress, sedentary behavior, and obesity. For instance, a woman with a 4-centimeter intramural fibroid may experience amplified uterine pressure, intensifying cramp severity. Prostaglandins bind to receptors on the myometrial smooth muscle, triggering intracellular calcium influx that drives powerful rhythmic contractions. Each contraction compresses spiral arteries, causing brief ischemia. The resulting hypoxia stimulates the release of additional nociceptive substances, bradykinin and leukotrienes, creating a positive feedback loop of pain. The intensity of cramps correlates with prostaglandin concentration. High-dose ibuprofen reduces prostaglandin synthesis and thereby lessens contraction amplitude. Clinically, women often report the most intense pain during the first 24 to 48 hours when prostaglandin levels peak. Dysmenorrhea affects an estimated 60 to 90% of adolescent females and up to 30% of adult women worldwide. Incidence is highest in the late teens and early 20s, with a gradual decline after the age of 30, likely due to hormonal stabilization and higher rates of childbirth. Populations with limited access to NSAIDs or health education report higher disability scores, underscoring socioeconomic influence on symptom burden. Typical manifestations include throbbing or colicky pain, localized to the suprapubic region, often radiating to the lumbar spine, sacral area, or inner thighs. Accompanying autonomic symptoms may comprise nausea, vomiting, headache, dizziness, and increased urinary frequency. For example, a college student might experience a 7 out of 10 pain rating, accompanied by a mild migraine during the first 2 days of menses, leading her to seek analgesia. Diagnosis is primarily clinical, based on a detailed menstrual history, onset, duration, intensity, relation to menstrual flow, and pain characterization. Red flags such as dyspareunia, dyschezia, irregular bleeding, or pain unresponsive to NSAIDs prompt further evaluation. Workup may include a pelvic examination to exclude structural pathology, transvaginal ultrasound to visualize fibroids or endometriotic implants, and laboratory tests, CBC, hormonal panels, when endocrine disorders are suspected. Secondary dysmenorrhea is confirmed when an organic cause is identified. Primary dysmenorrhea occurs in the absence of any pelvic disease, typically beginning shortly after menarche and improving with age or after childbirth. Secondary dysmenorrhea arises from identifiable gynecologic conditions such as endometriosis, adenomyosis, leiomyomas, pelvic inflammatory disease, or cervical stenosis. The timing of symptom onset helps differentiate them. Primary pain starts with the first few menstrual cycles, whereas secondary pain often appears later in reproductive life and may be associated with irregular bleeding patterns. First-line therapy includes NSAIDs, ibuprofen 400 to 600 milligrams, or naproxen 500 milligrams, initiated 1 to 2 days before expected menses, and continued for 48 to 72 hours. NSAIDs inhibit cyclooxygenase enzymes, decreasing prostaglandin synthesis. Adjunctive measures: heat application thermotherapy, aerobic exercise, yoga, and cognitive behavioral relaxation provide additional analgesia via endorphin release and improved uterine blood flow. For refractory cases, hormonal contraceptives combined oral pills, patches, vaginal rings suppress ovulation and stabilize endometrial shedding, thereby reducing prostaglandin output. When secondary dysmenorrhea is diagnosed, targeted treatment of the underlying pathology, for example, laparoscopic excision of endometriotic lesions, is essential. Preventive strategies focus on modifiable risk factors. Maintaining a BMI within the normal range, 18.5 to 24.9 kilograms per square meter, and engaging in regular moderate intensity aerobic activity, for example, 20-minute brisk walk daily, reduces prostaglandin synthesis. Dietary adjustments: limiting caffeine greater than 300 milligrams per day, reducing sodium intake, and increasing omega-3 fatty acids, fish oil, flaxseed, have been linked to lower inflammatory mediator levels. Initiating NSAIDs prophylactically, for example, ibuprofen 200 milligrams at the onset of menstrual bleeding, can blunt the prostaglandin surge and avert severe cramps. The outlook for primary dysmenorrhea is favorable. Most women achieve adequate pain control with over-the-counter nonsteroidal anti-inflammatory drugs and lifestyle modifications, and symptom intensity often diminishes after the third decade of life or after successful pregnancy. Prognosis for secondary dysmenorrhea depends on the etiologic condition. With appropriate medical or surgical therapy, such as hormonal suppression for adenomyosis or laparoscopic removal of endometriosis, pain can be substantially reduced, allowing return to normal activities. Untreated secondary causes may lead to chronic pelvic pain and infertility. Contemporary studies demonstrate that low-dose combined oral contraceptives using extended cycle regimens, for example 84-day cycles, significantly suppress endometrial prostaglandin production, achieving up to a 50% reduction in dysmenorrhea severity compared with standard cyclic pills. Emerging interventions include transdermal nitroglycerin patches that relax uterine smooth muscle by releasing nitric oxide, and dietary supplementation with omega-3 polyunsaturated fatty acids, which competitively inhibit arachidonic acid metabolism, thereby lowering prostaglandin synthesis. Ongoing trials are evaluating selective COX-2 inhibitors as a safer alternative for women with gastrointestinal contraindications to traditional NSAIDs.